morning, good afternoon, good evening, depending on where you are in the world. I'd like to welcome you to Harnessing the Potential of HER2, HER3, and TROP2 targeted therapies to address unmet needs in advanced non-small cell lung cancer. I'm thrilled to introduce my panel. I'm Melissa Johnson from Sarah Cannon in Nashville. I'll introduce you to Ben Levy, who is coming to us from Hopkins in Washington, D.C., and Helena Yu from Memorial Sloan Kettering in New York. Over the next hour, we plan to cover an incredible amount of information. Before we get started, I just wanted to say thank you to the Medical Learning Institute and PeerView for providing this educational session, as well as AstraZeneca and Daiichi Sankyo for educational grants that made this session possible. Please participate and join the audience polls that will be posted to you during the webcast. You can ask questions in the chat and they'll be submitted to us. We have time set aside at the end for questions. And on the slides that follow, you'll see all of our relevant disclosures. Okay, and just one other reminder, you can visit peerview.com /lung-ADC21 to watch the on-demand version of this live webcast in the next few weeks, as well as to download the slides and practice aids. You can also apply for CME and ABIM credits. So I hope that you'll take advantage of the whole hour, and certainly join us on Twitter by bringing @peerview into the conversation. All right, so let's jump right in. Here's our agenda for today. We're going to begin by discussing leveraging the increasing understanding of non-small cell lung cancer biology and biomarker testing. We're going to focus today on the roles of HER2, HER3, and TROP2 in the treatment of patients with non-small cell lung cancer. We're going to discuss the profiles of 3 new antibody drug conjugates targeting these targets, talk about the data that is supporting their development, and talk a little bit about testing to identify patients that would benefit the most from these therapies. We'll conclude with synthesis and some audience Q&A. Okay, so let's begin. You know, we don't have to go far anymore in non-small cell lung cancer before we begin the discussion of biomarker testing and how critical it is from the beginning, from the outset of our diagnostics and treatment of frontline lung cancer patients, to understand the underlying oncogenic drivers. There are all, now you see 1, 2, 3, 4, 5, 6, 7, 8, 9 therapies that are FDA approved based on the presence of the oncogenes that are summarized in the slide on the left. So there's never been a time where it's been more important to understand the molecular drivers of your cancer. We understand that there are still gaps in getting that biomarker testing done in all frontline lung cancer patients. It's a dialogue that should include not just the medical oncologist at your facilities, but also the pulmonologists and the pathologists, as well as payers. It's a big conversation, and we need to work together to make sure that we are maximizing the testing opportunities for our patients. So let's talk about what some of those new testing opportunities entail. I'm going to turn it over to Dr. Levy.
Thanks, Dr. Johnson. You've mentioned there are 9 now targets with approved therapies. Hopefully, HER2 will be the 10th coming soon. And so the HER family consists of 4 structurally related cellular receptors, which can interact in many ways. HER1, of course, is EGFR, and then HER2 and HER3 will be the subject matter for much of what we're going to discuss today. I don't think we fully understand HER4 and its capability to elicit tumorigenesis or be active in tumorigenesis, so we'll spend less time on that. But at least for HER1 and HER3, these can be HER1 through HER3. These are aberrantly activated in multiple cancers and can serve as drug targets, potentially drug targets. and biomarkers in precision therapy. And I think we'll talk about these. So in regards to HER2 mutations in cancer, mutations can occur in the active kinase domain, which is the structure you see on the left here, and also can occur in the transmembrane domain, which is the structure you see on the right. With regards to HER2 mutations in lung cancer, importantly, most of these are exon 20. They are insertions or duplications, and they mostly involve the kinase domain. When these mutations do occur in the kinase domain, this leads to homodimerization or heterodimerization of other HER family receptors that, of course, can then lead to constitutive activation and downstream signaling, including MAP signaling, and lead to uncontrolled tumor growth. Perhaps the most important slide as we begin as a primer is this one. And there's been a lot of confusion on nomenclature for HER2. And so just to take a step back, because I think this will become relevant in the things we talk about, HER2 can be overexpressed in lung cancer, and this is measured traditionally by IHC or immunohistochemistry. It can be amplified, and this is usually interrogated with either FISH or next generation sequencing. And it can also be mutated, and this can be interrogated or assessed by next generation sequencing. And I think this is important because we're trying to find that bona fide biomarker, and which HER2 alteration that is, I think we'll talk about. Importantly, and perhaps confusingly, there has been a lack of correlation between overexpression, amplification, and mutations. With regards to overexpression, this can occur in lung cancer anywhere from 15 to 30%. With amplification, it's anywhere from 2 to 5%. And then HER2 mutations, specifically those ones in exon 20, occur anywhere from 2 to 5% of all lung cancer. And again, I think we'll talk about this, but it's important to take a step back and look at these alterations to understand which of these alterations is relevant, which of them is going to be a bona fide biomarker, and which we can use, which should we use in everyday clinical practice. I'll turn it over now to Dr. Helena Yu.
All right, so I will do a little quick overview on HER3. So HER3 is really the kind of lesser known family member compared to EGFR and HER2. Unlike HER2 and EGFR, it actually lacks tyrosine kinase activity. And it itself is not actually an oncoprotein, but it actually heterodimerizes with other RTKs to activate oncogenic signaling. And then you can see from the figures on the right, actually mutations in HER3 or other alterations like amplification are actually quite rare in lung cancer and rare in other cancers as well. So HER3 is expressed in 83% of non-small cell lung cancers. HER3 overexpression is associated with metastatic progression and decreased relapse-free survival in patients with non-small cell lung cancer. HER3 alterations are not acquired as a mechanism of resistance to EGFR TKI therapy in EGFR mutant lung cancer, but because of its sort of omnipresence, targeting HER3 may be relevant across multiple EGFR TKI resistance mechanisms. And here is a slide reviewing those resistance mechanisms. So we all know that efficacy of EGFR TKIs in EGFR mutant lung cancer has been well established, although the development of various resistance mechanisms almost universally leads to disease progression at some point. Second-line standard of care treatment is platinum-based chemotherapy, which has modest activity in this space. And then salvage therapies after EGFR TKI and platinum-based chemo have more limited efficacy. So the figures on the bottom really illustrate that there is a wide variety of genomic alterations that are associated with EGFR TKI resistance. And interestingly, the proportion of resistance mechanisms that we see really vary depending on EGFR TKI utilized. So for the earlier generation, first and second generation EGFR TKIs, we largely saw acquired T790M as the dominant mechanism of resistance. With osimertinib, resistance is more varied, but really can be categorized into different subsets, including on-target resistance, which are acquired EGFR alterations, off-target, which are alterations or upregulation in bypass signaling pathways. We can sometimes see histologic transformation, and then especially for first-line osimertinib, resistance is largely unknown or not molecularly driven. Back to Dr. Johnson.
Now, unlike HER2 and HER3, thanks, Dr. Yu, unlike HER2 and HER3, you may not have heard of TROP2 before being a relevant biomarker in non-small cell lung cancer. It certainly is the new kid on the block as far as I'm concerned. It's a transmembrane protein, glycoprotein. It's highly expressed in non-small cell lung cancer and other tumors as well. And high levels of TROP2 expression are associated with a poor prognosis, which makes it a very tempting drug target. There is currently no clinical standard testing for TROP2, so we can identify it by IHC, but it certainly isn't part of clinical practice. Next slide. I guess I can control the next slide. But before we go there, I've given you the final answer on TROP2. We're not yet checking for it. But let's talk a little bit about HER2 and HER3. Are these relevant biomarkers that we're testing for now? If you close your eyes and think about the patients that you see in your clinic, are you aware which ones of them have a HER2 mutation, for example? Ben, maybe I'll ask you to talk about how often you think about HER2 in your practice.
Yeah, great question. And, we do comprehensive genomic profiling on all our patients, and this will include HER2 mutations. So we do get this information back. We need to look closely at the next generation sequencing report just to make sure that these are potentially druggable. These are, again, insertions or duplications, most commonly in exon 20. We have these, and we look at these because we do have clinical trials with novel therapies. I think it's really important that we try to identify these and wed these targets to potential drugs that most likely will get approved in the next 6 to 12 months. But I think this is something that we need to look at. We have a fair amount of patients that we've identified and can link and wed to particular targeted therapy or novel therapy that may offer meaningful benefit for the patient.
And thank you. And what about you, Dr. Yu? Are you testing for HER3?
Yes, and I wanted to add one thing on HER2, just saying that I think it's complicated. I think most NGS profiles do also check for HER2 amplification, which I think can be a biomarker for those HER2-directed therapies. But at least at our institution, we're not routinely checking for HER2 expression. So I think that's also still an evolving field, the different HER2 biomarkers. And for HER3, no, we're not actually testing for this. I think, what we're going to go over the data. As of now, none of the clinical trials that are concerning HER3 drugs actually pre-specify the need for HER3 expression. And so if we don't have to test, and if there is a kind of specific clinical subset of patients, where say, EGFR mutant lung cancer after progression on EGFR TKI and chemo, that might be the way that we can enrich or select for people that would have better benefit from the HER3 ADCs.
Thanks, Elena. So let's jump right into the next part of our discussion is entitled Clinical Accelerator. And so I think what this means to me is given we've told you now where we're going, now we're going to show you the data that's going to get us there. And we're going to start with a discussion of HER2.
Great. So I'll start this. So thanks, Dr. Johnson. So just a little bit about how we're trying to exploit HER2 alterations in lung cancer, particularly some of the newer therapies. We've, of course, had single epitope monoclonal antibodies like trastuzumab and pertuzumab that have been looked at. Small molecule inhibitors like lapatinib, commonly used in breast cancer. We've tried to look at them also in lung cancer, specifically for HER2 mutated lung cancer. And then bispecific antibodies, again, some of the ones we're starting to use in lung cancer, but others more relevant in the HER2 space are in breast cancer. And then more recently, and probably the focus of much of the discussion we're going to have today, is in antibody drug conjugates. And just to take a step back on a primer on ADCs, importantly, the construct of an ADC contains three key components: the antibody, the linker, and then a warhead or a payload. And I think each of these components has to be thoughtfully designed to balance out efficacy and tolerability. And so that's just a brief primer on these ADCs. How do they work? I think we're still learning about these and the way that they work, specifically in lung cancer. I think the punitive mechanism of action is really that the monoclonal antibody or the antibody targets antigen-expressing cells or tumors. These agents are then internalized and the payload is released into the tumors by lysosomal enzymes. You can get what, and we'll see in a future slide, this bystander effect, which is that you get the payload is able to go through membranes and attack neighboring cancer cells. Not listed on this slide is this whole idea of antibody-dependent cellular cytotoxicity, or ADCC. This is an idea where the Fc component of the antibody can elicit immunogenicity and elicit an immune response. That may be another way that these drugs work in lung cancer. This slide is just showing you that bystander effect, at least preclinically. And what you're seeing here is that some ADCs have been shown preclinically to elicit a bystander effect. The HER2 positive cells are showing regression, as well as neighboring HER2 negative cells. And so I think this is a theoretical advantage to some of these new antibody drug conjugates that can elicit not only cell kill within the antigen expressing cells, but also neighboring cells that may not express the antigen. So the story of ADCs, or the beginning, started with trastuzumab and tansine. This was a study carried out in a small number of patients, roughly 18 patients. Patients were pretreated. The prior line of therapy was 2. These were 18 patients, all HER2 mutated, who received trastuzumab and tansine every 21 days. And small numbers, but response rates north of 40%, 44%. The swimmer's plot you see here on the right showing that many of these patients remained on therapy. The progression-free survival was modest at around 5 months, but remember that this was an average line of therapy of 3. Now, there's been an updated analysis from this study recently published showing both HER2 mutated and amplified. But for the sake of the conversation, we'll stick to the HER2 mutated cohort and talk maybe about the relevance of HER2 amplified in the next data set. The next drug that has come along has been trastuzumab deruxtecan. This is an ADC again, the 3 components: a humanized HER2 targeted monoclonal antibody, a linker, and then a topoisomerase 1 inhibitor payload. And so this drug has also been looked at in clinical trials, and perhaps the one that's been front and center for this drug has been the Destiny Lung 1 study. This was looking at patients with unresectable non-squamous non-small cell lung cancer, relapsed to standard treatment. The median line of prior therapy was 2, so this was given at an average line of 3. Patients were either HER2 expressed or HER2 activated, had a HER2 activating mutation, so there are 2 cohorts. Cohort 1 was the HER2 overexpressed, cohort 2 was the HER2 mutated. The primary endpoint was response rate. What we saw from this study was compelling. The response rate of north of 60%, again, in a highly pretreated group of patients receiving single agent drug, all with HER2 mutated lung cancer. There was durability with these responses. And we'll see this in the waterfall plot here, again, showing response rates of 60%, and the swimmer's plot showing you that many of these patients remained on therapy for quite some time. If we look at the progression-free survival and overall survival from this cohort, the PFS was 14 months, more than a year, and the overall survival has not been reached. So fairly compelling to see this. This is probably some of the best data we've had for HER2 mutated lung cancer with a single agent drug, or any drug for that matter. If we look at the overexpressed cohort, little different story here. The response rates anywhere from 20 to 25%. One would have thought, based on how these drugs work, that overexpression of HER2 may have been the right predictive biomarker for this drug, but we see a response rate that's about half, if not a third, of what we saw in the HER2 mutated lung cancer cohort. So jury's still out whether IHC may be a predictive biomarker for this HER2 ADC. You can't talk about efficacy without, of course, talking about tolerability. There are safety signals here. I mean, at least in the cohort 2 of HER2 mutated lung cancer, more than a quarter or close to a quarter had to discontinue drug due to a treatment emergent adverse event, and roughly a third had to have some sort of dose reduction. Toxicities we see with this drug, generally cytopenias, neutrophil count or neutropenia, fatigue, nausea. Another toxicity to be on the radar is interstitial lung disease or pneumonitis. Most of these were grade 1 or 2, but as these drugs unfold in our clinic and in our clinical trial portfolios, we need to be mindful of this toxicity as we move forward with these drugs. What's next? Well, the current and future development of this drug, there's a lot of different trials that are currently phase 1 and 2 ongoing. I will tell you, I'll put my nickel down and tell you I'm excited about some of the phase 3 trials. They may not be super scientific, but trying to answer clinically relevant questions, looking at single agent drug versus standard of care chemotherapy and HER2 mutated lung cancer. I think that's a meaningful trial that I hope will get good results on, or at least positive results or meaningful activity with this drug in a phase 3 trial, since we've already seen this in the phase 1-2 experience. So I'll turn this over now to Dr. Yu to discuss HER3 data.
Okay. So there have been many prior attempts to target HER3 within cancer. I think many of them have actually focused on EGFR mutant lung cancer and have been primarily naked antibodies to HER3 or trying to utilize pan-HER TKIs. Without much success. So nothing that really looked successful in this space in that patient population. So patritumab deruxtecan, it may look similar to the T-DXd, and it is in some ways. So patritumab deruxtecan is a novel anti-HER3 ADC. It includes a monoclonal IgG antibody against HER3, a linker, and then a payload, which is actually the same payload as T-DXt. It's an exatecan derivative. Mechanism of action is a topoisomerase I inhibitor. So the pivotal study that looked at this drug within lung cancer, we have experience in approval or experience prior in breast cancer, was the study. So it looked at this drug in locally advanced metastatic non-small cell lung cancer with EGFR mutations. Patients needed to progress on prior EGFR TKI treatment. When you look at baseline patient characteristics, everyone had prior EGFR TKI. The vast majority had prior osimertinib, the third generation EGFR TKI, and prior platinum-based chemotherapy. And about 40% of patients also had prior immunotherapy. And this was also a patient population that was heavily pretreated with a median of 4 lines of prior systemic therapy prior to enrolling on study. So the dose escalation assessed escalating doses of HER3 DXd, and then the dose of 5.6 milligrams per kilogram was selected as the dose to move forward in the dose expansion as the recommended phase 2 dose. So HER3 DXd demonstrated durable anti-tumor activity in this patient population. So in patients that had prior osimertinib and prior platinum chemotherapy, the confirmed overall response rate was 39%, disease control rate 68%, time to response short at 2.7 months, duration of response 7 months with a median PFS of 8.2 months. So I think this is a great figure. So this is the waterfall plot of percent shrinkage of cancers on this clinical trial, but overlaid is the kind of initial sensitizing EGFR mutations, as well as mechanisms of resistance to EGFR TKI that were identified on plasma and or tumor tissue. So I think the important take-home points are that the phase 1 allowed different activating EGFR mutations, and we saw responses even in some of the atypical exon 18 EGFR mutations. And then importantly, really there seemed to be activity in a diverse, within diverse mechanisms of resistance within cancer. So patients with MET amplification, KRAS alterations, BRAF fusions, acquired EGFR alterations like C797S still had responses HER3 DXd. And I think that that's important because as we showed earlier, the mechanisms of resistance to osimertinib are quite diverse. And so we really need to think about agents that may be able to transcend those mechanisms of resistance and be effective in a larger patient population. So this is the swimmer's plot of patients on that phase 1 study. You can see that patients remained on study for a relatively long period of time, with a third of patients still on treatment at the time of last data cutoff. It's small, but if you can see on the bars on the left, about half of patients had a history of CNS metastases prior to going on study, and there were still durable responses seen in those patients. And then at the end of the swimmer's bars, you can see that it says kind of areas of progression, and you can see that there are actually relatively few patients that had progression within the brain. And I think that this, of course, will be very important because in this class of ADCs is really trying to understand how well these drugs or this class of drugs penetrates the blood-brain barrier. So clinical responses were observed across the spectrum of baseline HER3 expression. So the study actually did not select patients for HER3 expression. It actually allowed all patients to enroll, but retrospectively, tumor samples were mandated from all patients. And of the 43 patients that had tumor tissue available, all had some level of HER3 expression, although you can see from the figure on the bottom left that the HER3 expression as measured by H-score really varied a lot among the different samples. They looked at the HER3 expression levels and time since last EGFR TKI, and there didn't seem to be any correlation there. And then, of course, we want to see if degree or amount of HER3 expression correlated with response. And we really didn't see that to a large degree. You can see that the HER3 H-scores for patients with confirmed partial responses, stable disease, and progressive disease had significant overlap. So it's not clear whether HER3 expression will emerge as a biomarker in this space. Of course, important to go over safety. In terms of treatment emergent adverse events that led to a dose reduction, that was in 22% of patients, and treatment emergent adverse events that led to treatment discontinuation was 9% of patients. I think it's important to remember that there is a chemotherapy portion to these ADCs, and so we see some of the sort of commonly seen with chemotherapy adverse events such as thrombocytopenia, neutropenia, nausea, fatigue. And so those are sort of a class effect of these ADCs. And then ILD to focus on. So actually, when looking at the ILD frequencies, it was a little less than with TDXD in this study, ranging from 5 to 7%. There were no grade 4 or 5 events of ILD. And so in summary, we really do see clinically meaningful, durable efficacy with that overall response rate of 39% after TKI, after chemotherapy in a heavily pretreated population. There did seem to be efficacy across different EGFR TKI resistance mechanisms, and anti-tumor activity was observed in a wide range of baseline HER3 expression levels, and safety did seem manageable. And so based on this initial phase 1, there is a confirmatory phase 2 study, the HERTHENA Lung 01 study, that is taking that same patient population, focusing now on exon 19 and L858R, patients that have had prior osimertinib and prior chemotherapy, and then randomizing them to sort of different doses of HER3 DXd. And this study is ongoing and open to enrollment. And then the snapshot on kind of current and future clinical development. Of course, this looks to be kind of studied in the space of post-TKI and post-chemo, and we'll see if that confirmatory study kind of reiterates the efficacy and the toxicity that we saw with the initial phase 1. And then the other study that I'm interested in is a combination study with osimertinib that is being looked at immediately after first-line osimertinib progression, and that study is also ongoing. And now I will hand it over to Dr. Johnson to talk about TROP2.
Thanks, Dr. Yu. All right. So one last ADC to talk about. Here we see a very similar diagram of the different parts of the anti-TROP2 ADC. Once again, the antibody that's directed against TROP2, the payload, and then and the linker, and then the payload, the exatecan payload. Just want to point out, and we'll talk about this a little bit more during the discussion, that that payload is identical with the HER3 ADC, the HER2 ADC, and now TROP2. And so what the implications of that are, I don't think we know yet. DS1062, Dato-DXd, as it's now known, datopotamab deruxtecan is its official name, has been studied in a large pan-tumor phase 1 study, the schema for which is shown here. Patients with relapsed and refractory metastatic non-small cell lung cancer with having good performance status and measurable disease by RECIST were enrolled. Brain metastasis were allowed as long as patients were previously treated. And then patients were treated at escalating doses of Dato-DXd. 3 different dose levels were identified as showing efficacy: 4 milligrams per kilogram, 8 milligrams per kilogram, and 6 milligrams per kilogram in the middle. And those 3 were then evaluated in a non-small cell lung cancer cohort that we'll discuss today. I think it's important to note too that a triple negative breast cancer cohort has subsequently enrolled, and now bladder and gastric esophageal cancers are now enrolling in this trial. So the primary endpoint was maximally tolerated doses, and so here you see a summary of the 3 doses that were evaluated. You see, first of all, I point you to the grade 3 related adverse events, the grade 3 drug related adverse events, higher with the increasing doses of the drug. Likewise, the treatment emergent adverse events associated with discontinuation, drug interruption, as well as dose reduction, all increased as the dose was increased. And so while 8 milligrams per kilogram was initially selected, then 6 milligrams per kilogram was subsequently deemed the randomized or the recommended dose for further study, making 8 milligrams per kilogram the maximally tolerated dose. On the right-hand side, you see a plot summarizing the treatment emergent adverse events by dose. Once again, this is a chemotherapy, and you see that reflected in the adverse events most commonly. Nausea, stomatitis, and fatigue were the adverse events most commonly seen. Alopecia, a class effect seen across all of the drugs as well. So here's the best overall response rate. So this was a phase 1 study, so this was a secondary endpoint. Once again, you might have expected that as you go from 4 milligrams per kilogram to 6 to 8, you would see an increase in objective response, but actually we saw that patients with 6 milligrams per kilogram had the best response rate, and maybe that's because the patients at 8 couldn't stay on long enough to have a confirmed response. They certainly around 40 to 50% of patients had stable disease, with the duration of therapy about 10 months. Pretty respectable for a phase 1 compound. On the right-hand side, you can see the waterfall plot showing responses at 4, 6, and 8. And likewise, the spider plot across the bottom showing the depth of responses at 4, 6, and 8. Not really any more durable at any of those time points, but 10 months, the median of duration. So because Dato-DXd showed encouraging anti-tumor activity and manageable safety profiles at the 3 doses, 6 milligrams per kilogram was selected for further development. And so we are looking forward to next week when we'll hear the results of this TROP ion pan tumor in patients with advanced metastatic non-small cell and actionable genomic alterations. So this was a subset of this phase 1 trial, including patients with EGFR, ALK, and ROS1 alterations that were treated with this DS-1062. So a TROP2 directed therapy in these oncogene-directed cancers is sort of an interesting flip, a little different from what we're seeing, and that's a late breaker that coming to ESMO next week. But meanwhile, the development of DS-1062 Dato-DXd continues in a large phase 3 pivotal study in which patients previously treated with platinum and immunotherapy are randomized to receive Dato-DXd at 6 milligrams per kilogram versus docetaxel at 75 per meter. The primary endpoints you see PFS and overall survival, big trials, 600 patients to be randomized. So we look forward to the results of this trial coming soon, as well as the data in patients with actionable genomic alterations, AGA. And we also have some idea that this chemotherapy may in fact be able to be substituted for some of the platinum partners that we've used heretofore, so that we could bring this Dato-DXd up until the front line. You see the study design for some of the cohorts in lung 02 and lung 04 show patients treated with carboplatin in combination with Dato-DXd or cisplatin plus Dato-DXd. And if I'm not mistaken, the intent is also to then add pembrolizumab in lung 02 and durvalumab in lung 04. So exciting opportunities even in the front line. And then finally, TROP ion lung 05 is the actionable genomic alterations study, enrolling not just EGFR, ALK, ROS1, but also BRAF, MET, NTRK, and RET to receive in a single arm trials 6 milligrams per kilogram. So this TROP ion lung 05 is also enrolling. Okay, but a discussion of TROP2 would not be complete without reminding us about another TROP2 antibody drug conjugate that has already been in development, actually, in the triple negative breast cancer space for a while. Sacituzumab govitecan, another antibody drug conjugate that shows us response rates once again in the high 20s here. This is data actually from a few years ago, published in OncoTarget, but it's a very similar molecule with an SN38 payload, similar payload to Dato-DXd. The PFS 5 months and the overall survival 9 months. So maybe not looking quite as good as Dato-DXd, but obviously the ongoing trial, TROPiCS-03, the schema for which is shown in the bottom right, will be really important to compare data from one trial to the other. This is a multi-cohort trial enrolling not just lung cancer, but also head and neck and endometrial cancer patients. And that is activating many places soon. Okay, so we've given you a lot of data over the last 20 minutes, or 30 minutes, I should say, and it now is the time where we hope to help you consolidate this data and figure out how you would use it in your clinic come tomorrow or maybe in months to come. So we have a case and we're going to discuss the case among ourselves. Happy to take questions in the chat. I want you to close your eyes and channel your favorite 75-year-old female never smoker in your clinic, diagnosed with an EGFR mutant lung cancer in November of 2019. She had an EGFR L858R exon 21 substitution mutation. She was treated with osimertinib successfully between December of 19 and May of 2020. At progression, she received carboplatin and pemetrexed for 4 cycles, and then had been on maintenance pemetrexed for another 9 months. In June of 2021, she returned to your clinic with complaint of fatigue with this PET scan, showing recurrence in her left supraclavicular fossa, as well as showing left hilar recurrence and left adrenal metastasis. She had a Guardant 360 pulled in your clinic that day that confirmed her EGFR L858R mutation, showed some EGFR amplification, CCNE1 amplification, and a PIK3CA mutation. So maybe I'll start with Helena. Dr. Yu, can tell us some of the things that, maybe before we go to the answer, what are some of the things that you're thinking of as you dissect this case and are deciding on what her next steps should be?
Sure. I guess I would want to know, so things that I'm thinking about is on that sort of repeat PET scan in June, did we see sort of fast growing progression? Is she symptomatic? Are we, was the kind of tempo of progression significant? And I think that because I wonder, whether a repeat tumor tissue biopsy would be useful. So, I think that the one thing that our molecular testing and liquid biopsies are not able to detect is histologic transformation. And so I would want to, if the clinical scenario is right, I usually do a repeat tumor biopsy so that we can just, look for that. And then I'm looking at the Guardant results and I'm looking for, is there something that might be mediating the resistance? I think this is a little bit of a more nuance, but I think obviously she had most recently got chemotherapy, but, she prior to that did get Tagrisso, so osimertinib. So, is there something post osimertinib that might be targetable? And I don't really see anything. I'd be looking for potentially an acquired EGFR alteration, a BRAF alteration, an ALK fusion. All of these are super rare, but, could be something that might be targetable on a clinical trial. So I think there I'm not seeing that. And then I'm sort of thinking, okay, so nothing obvious on the mutation results that tell us what to do. So what are our kind of clinical trial options and what are our standard treatment options?
Okay, great. So now we'll go to the next slide, which does summarize both our standard of care options. I think we'd all agree that docetaxel with or without ramucirumab would be the standard option. And then we have a couple antibody drug conjugate clinical trial options if you have them available. Here you see the HER3 ADC, patritumab deruxtecan, of course, that Dr. Yu reviewed with us, a great option, and the current clinical trial enrolling patients after osimertinib and after a platinum-based doublet. So she would be a good candidate for that. She also might be a candidate for datopotamab deruxtecan, or the TROP2 antibody drug conjugate that I reviewed. Remember, I told you, wink, wink, there's data at ESMO that is going to focus on actionable genomic alterations using this compound. And certainly there are trials that are already in the works. The one that I wouldn't recommend for this particular patient is the HER2 ADC, trastuzumab deruxtecan, or HER2. Obviously, she doesn't have a HER2 mutation. HER2 overexpression was not seen on her Guardant 360, and so that would be the one that that I would rule out at the beginning. So let's twist the case just a little bit and go back to our case. This is still a never smoker, but this time the patient has an EGFR wild type alteration with NGS showing STK11 this time, ARID1A, P53, and an ERBB2 mutation. So she's treated with platinum, pemetrexed, and pembrolizumab successfully for 3 months, followed by pembro alone until May, when her scan shows progression, as you see on the right. And her Guardant 360 is unremarkable. So now I'm going to call on Dr. Levy. Tell us a little bit about your approach in this case.
Yeah, it's not too dissimilar to how Dr. Yu approached the EGFR case. I think, this patient's had a reasonable run. This is a very common scenario. Patients treated with triplet therapy with carboplatin, pemetrexed, pembrolizumab gets some significant benefit. 2019 December all the way to May 20. So it gets about 19, 20 months of benefit. And then, one of the things I look at in these cases, I try to define progression. What is progression? Is this oligoprogression? Is this slow progression? Or is this true systemic progression where a therapeutic switch is warranted? And that, I think, is really important. The one thing that I would add to this case, or there would be two things. One would be I'd probably do another MRI of the brain. When we see systemic progression like this below the neck, we want to assess intracranially to see if there is a progression in the brain. And then, the Guardant was negative, which really doesn't tell us that much. We know that about 30% of patients don't shed circulating tumor DNA. And so that doesn't mean that alterations don't exist in the tissue that can't be identified. So I would probably, even though we know this patient has a HER2 mutation, I would probably want to opt for a repeat tissue biopsy as well to evaluate what we would do. Would it change my mind outside of finding something other than the HER2 mutation? Probably not. But it's helpful to know for subsequent trials. So I would probably define the progression, which here seems systemic, seems like a therapeutic switch is warranted. I would get a brain MRI, and then I would do a tissue biopsy with a comprehensive genomic profiling and tissue interrogation.
Perfect. Thanks, Ben. And here we have, once again, just to wrap it all up, standard option with docetaxel plus minus ramucirumab. Trastuzumab deruxtecan might be an option on a clinical trial. Of course, there are others. So let's start to put it all together. This lung cancer continues to evolve, but continues to be complicated. We know that just as important as doing the next generation sequencing that Ben talked about is the PD-L1 testing that we talked about as well, to determine patients that will do better with monotherapy immune checkpoint inhibitors or combination if no drivers found. So here on this slide, we've summarized sort of the state of the current art. For patients with PD-L1 high tumors, all the way on the right, you see these patients can be treated with monotherapy or probably combination approaches. You see for patients without an oncogenic driver who have PD-L1 less than 50%, there the histology becomes more relevant because we'll add platinum-based chemotherapy in combination with monotherapy, PD-1 inhibitor, PD-L1 inhibitor, or combination PD-1 anti-CTLA-4 quadruplets now. So for EGFR and HER2, you see on the left-hand side of the screen, lots of frontline options for patients with EGFR mutations. And then at progression, osimertinib, of course, versus chemotherapy. While for patients with HER2, the verdict's still out on whether chemo with or without immunotherapy is best. So now let's overlay our treatment options. As we've discussed today, you see that the trastuzumab deruxtecan may find its way into the front line because, of course, a response rate of 60% is equal or better to what we can expect with chemo IO for patients with HER2 mutated lung cancer. For TROP2 antibody drug conjugate, we're using this like right now in the second line. That's where that lung 001 trial is being evaluated versus docetaxel, so post chemo IO. And then the HER3 antibody drug conjugate, likely after initial TKI exposure and right now after platinum pemetrexed, with some look towards or some question about whether it might inch its way up into the second line before patients go on to platinum pemetrexed chemotherapy. Helena and Ben, anything to add here? Anything that I didn't mention?
I'll just mention in the HER2 space, I agree. I think that we're going to have to define what HER2 alteration that we're talking about. And if we're talking about HER2 mutations, it's hard for me to believe that a single agent drug that elicits a response rate of 60% in the third line won't be a higher response rate in the first line. So I think, and that's why I look forward to the phase 3 trial that will hopefully definitively answer this question, a HER2 ADC with trastuzumab deruxtecan versus chemotherapy with immunotherapy for HER2 mutated lung cancer in the treatment naive setting. So I look forward to seeing that. It's going to take a while to accrue, and it's a phase 3 trial, but this drug may get approved and we may start using it in the front line. I think obviously the jury's still out for HER2 amplification or HER2 IHC. I don't know if these are truly predictive for HER2 directed therapy. I guess we'll see. There'll be future data sets looking specifically at these alterations, but I'm excited. I think HER2 mutations will be the 10th biomarker, and I think trastuzumab deruxtecan will be a drug that we'll start using in our clinic hopefully soon.
Thanks, Ben.
My comment to add is that, I think it's interesting to, there's so many ADCs that are in clinical development now, and I think all of us are really excited about these. We're now well familiar with the kind of mutation driver pie, and I wonder if sort of a second overlay on that is going to be some sort of kind of expression. Will we have some kind of multiplex expression where we're looking for all of the, MET, TROP2, HER3. So, that more to come there, I think. That's super interesting. And then I think the other thing to consider is, these drugs, even, when you think about TROP2, they're still very active. I mean, when we're thinking about comparing them to second line docetaxel, even in all comers, there really is, reasonable activity for these phase 1 studies. And so I wonder, I think the bar of sort of the efficacy is going to really depend on where we want to put them in our kind of our treatment sequencing, right? So I think, if for the TROP2 ADC, for example, in the second line setting, maybe we would do all comers, but maybe if we could select for a patient population for that or other drugs where the response rate is higher, and be that by, IHC or some other factor, that there'd be the ability to move some of these drugs up even earlier. So I think that's going to be something emerging too. It's, what is the response rate for all comers, and is there a way to select or enrich for a subset that really has a better sort of response rate? So exciting.
Can I just make one quick last point, is, while we're trying to figure out where these drugs fit in the treatment paradigm, the other thing that I think we're going to have to learn is the toxicity of these drugs and how to manage some of these unique toxicities that we may not see with genotype-directed therapy or immunotherapy or even chemotherapy. And I think we're learning that in some of the clinical trials that we're all participating in, how to manage and mitigate some of these toxicities that are coming out from these drugs.
Yeah, that's a great point, Ben. I have another question for you both. Ben, you mentioned the phenomenon of the bystander effect and how it's critical to the efficacy of an antibody drug conjugate. So I'm curious, as you think about, for example, the response rate of 60% in the patients with HER2 mutated lung cancer and the response rate of 25% or so in the HER2 overexpressed lung cancer. Is that really that there's something important about the HER2 overexpression, or is that just the minimal bystander effect that we should expect from this platform?
I have to answer this first. I'm the unlucky person that has to answer this.
I'm curious about your thoughts.
I've
It's
heard,
fascinating to me.
I've witnessed and listened to a lot of different thoughts on this and why this occurs. Why are we seeing such a higher response rate in the HER2 mutated versus the HER2 amplified? I've heard everything from we're not really sure to that actually HER2 mutations are just more chemosensitive, and we're using a chemotherapy linked to the monoclonal antibody. I don't really understand. If you would have told me before this all started that the HER2 overexpressed had a lower response rate, it's hard for me to understand. Does some of this have to do with a bystander effect? I'm not really sure. I don't have a good explanation. I still don't. I've listened to a lot about why HER2 mutations may be the right predictive biomarker for this drug, whereas HER2 overexpressed may not be. That was a hedge of an answer, by the way. That means
well, it was a good answer. You answered it well. Helena, maybe I'll pass the heat lamp over to you. And I think remember that the other group of patients that the patritumab deruxtecan phase 1 trial enrolled were patients that were EGFR wild type. And while the focus of this drug and where it's effective is clearly in the mutated patients, but that actually is the group of patients that I'm curious about. Did you treat any patients in that cohort out of curiosity, and did they have response?
Yeah, we didn't, but I am also eager to see that data, because what if it is, again, around that 20 to 25% response rate? And I think that also brings up the question, I think Ben's points were all great, but also like how little of the target do you need for these drugs to penetrate and be effective? So I think, and we remember these are chemotherapy drugs, but there's something magic, there's magic sauce there, because, for all of these, the payload is, kind of an exatecan. So it's in the irinotecan, topotecan family that we know really is not active in non-small cell lung cancer. So there's something about this ADC kind of mechanism of delivery that's doing something more. But yeah, super interesting. I think it'll be very interesting if it's there's that kind of baseline bar that we're seeing with all of these.
And then there are a number of questions from the audience in the chat about the interstitial lung disease. And, many of our colleagues that are maybe listening in today have had the chance to use at least trastuzumab deruxtecan in their breast cancer patients, because it's approved there, of course. And so they may have seen this already, but I'm curious if you have seen any association in your patients with chest radiation or immunotherapy. Curious if you guys remember the data evaluating that association in your respective trials.
So I can start. We participated in the datopotamab trials and have quite a few patients on, and we have had a couple of grade 1-2 interstitial lung diseases that from these patients, but none that I remember had prior radiation. I'd have to go back. I think this is a call for us to continue to partner with our subspecialists and our pulmonologists, especially when it comes to ILD. I watch this carefully. It can happen. We haven't seen any catastrophic events for our patients, but we've had roughly 10 patients on these studies, and maybe 1 or 2 have had an ILD that has been a grade 1 or 2.
How about you, Helena? In comparison to the ILD that sometimes we see with these EGFR mutated patients on a TKI, for example, or a TKI plus IO, do you have a comparison or comment at all?
No, I just want to say, I think same as Ben, we have the HER2 and the HER3 ADCs here. And it really seems like to be a class effect, right? Not just these exatecan sort of Daiichi agents, but in other ADCs as well. And again, I just think not well understood. But I think the more we partner with our kind of pulmonary colleagues and try to figure out ways to best manage it. And I think lung cancer is different too, right? These rates of pneumonitis are higher than what we've seen in breast cancer, but that seems intuitive in some way too with these, these patients have lung cancer pathology already present. So does that predispose in any way? But
I think there was data with Dato-DXd early on showing no association with prior immune therapy or chest radiation. So many of our patients have had those therapies that I would think that would be a little bit of a challenge to develop a drug if there was that association. So I was relieved to see that analysis that was reported a year or 2 ago. And I wonder if we are used, or our patients are used to tolerating a little bit of shortness of breath because of their cancer or because of the radiation that they've had or the lobectomy that they had in the past, where the breast cancer patients, this is a different organ, and so they're sensitive to it. Of course, the way to manage it is grade 1 is just you see the you see the changes on scans. That can also be a little bit more challenging for lung cancer because sometimes it spreads in a lipidic or intraalveolar way. At grade 2, it's symptomatic. And so when you have a grade 2 pneumonitis, that's a reason to start some steroids. And certainly grade 3 would be a reason to stop the drug permanently. The Daiichi and now AstraZeneca has an interstitial lung disease adjudication committee. So they have an objective group of people that come together and look at whether or not these findings reported by investigators are in fact ILD. And so I think we will learn more as time goes on, but it certainly isn't, it doesn't happen often enough. We've participated in all 3 of these efforts to not consider the drug, in my experience.
Agree.
Well, we're coming to the end of our time. I think I just encourage you to submit your post-test at peerview.com lung ADC 21, as well as your evaluation that will afford you the opportunity for CME or ABIM credit. And we'd love to see you on Twitter. Let us know what we missed, and so we can get it next time. And thanks for taking time out of your busy day to be with us today. Great to see everybody. I want especially to thank Dr. Yu and Dr. Levy for joining me as presenters today. Couldn't have done it without you. And I'd like to thank the peer review team for their help.